breath of oxygen, red blood cell exchange transfusion in sickle cell and COVID-19. Sickle cell disease is one of the most common hemoglobinopathies in the world. Two major complications are vaso-occlusive crisis and acute chest syndrome. You can see here in the diagram on the right, with the abnormal hemoglobins in sickle cell, there's a blockage of blood flow leading to the above complications. Currently, with a worldwide pandemic, there has been overlapping clinical presentation between life-threatening pneumonia and the acute chest syndrome. And we present today the first documented patient with history of hereditary persistence of fetal hemoglobin in COVID-19 infection. And we present the idea of potentially benefit from early red blood cell exchange transfusions to prevent rapid deterioration in clinical status. This is a 69-year-old female with past medical history of sickle cell anemia with mild phenotype from the hereditary persistence of fetal hemoglobin, presented to the ED due to joint pain and fevers for the past couple of days. She denied chest pain and a dyspnea, cough, nausea, vomiting, diarrhea. She mentioned that she tested positive for COVID at an outside facility, and the repeat testing in the ED was positive for COVID-19. Her vitals and physical exam were unremarkable upon admission. She was ultimately admitted for sickle cell crisis with symptomatic anemia with hemoglobin of 6.4 and COVID-19 pneumonia. She was transfused 1 unit of packed red blood cells and ordered convalescent plasma. She was started on azithromycin, ceftriaxone, zinc, vitamin C, and oxygen supplementation. Looking at Table 1 of the imaging studies, upon admission, chest X-ray showed mild perihilar interstitial infiltrates and edema, mild peripheral right ground glass infiltrates, pneumonia considered. They did a CT angiogram of the chest in the ED, which showed extensive bilateral ground glass subpleural opacity, as seen consistent with COVID pneumonia. No evidence of any pulmonary emboli. Looking at Table 2 of the hemoglobin electrophoresis that they did upon admission, hemoglobin A level was 92.1%, which is low. Hemoglobin A2 was 2.5. Hemoglobin C and hemoglobin F were 0%, despite her history of the hereditary persistent fetal hemoglobin. And then her hemoglobin S level was 5.4%, which is elevated but not severely elevated. So with her hospital course, a rapid response was called 2 days after admission for shortness of breath. It was noted that she was statting 87% on non-rebreather and using accessory muscles. The plan was for her to be transferred to the ICU. Ultimately, she had to be intubated because of respiratory distress. The plan was to do a red blood cell exchange transfusion, which was performed later that night with 10 units of packed red blood cells that were hemoglobin S negative and leukocyte-reduced red blood cells. Because of this transfusion, she was also transfused another unit of convalescent plasma after getting her first unit of the convalescent plasma after her admission. Ultimately, she was extubated and transferred out of the ICU after 48 hours of treatment, particularly responded to the red blood cell transfusion. Hemoglobin S becomes poorly soluble when deoxygenated, leading to the vaso-occlusive crisis and acute chest syndrome. We know patients with sickle cell disease are immunocompromised, so they are at increased risk of infections. Like any other respiratory viruses, the COVID-19 virus may cause pneumonia, leading to acute chest syndrome and respiratory failure. The hypothesis is that the COVID-19 virus affects normal functioning structure of hemoglobin, and so by directly addressing the hemoglobin itself, we may be able to prevent the rapid deterioration in clinical status. And the goal of the red blood cell exchange transfusion is to lower the hemoglobin S levels to 30% or less and to correct any potential anemia. By lowering the hemoglobin S level, we're able to limit the sickling complications. In our particular patient, she didn't have high levels of hemoglobin S, but they were still elevated. There have been other case reports stating that by conducting red blood cell exchange transfusion after admission and prior to respiratory deterioration, it may prevent intubation and potential ICU admission. In particular, for our patient, she got intubated, then received the red blood cell exchange transfusion, then received another unit of convalescent plasma after her first dose. She quickly recovered after 48 hours, which is relatively fast compared to other patients with COVID-19 pneumonia. If we were able to offer her red blood cell exchange transfusion prior to respiratory deterioration, potentially we could have prevented intubation and ICU admission. Limitations about this potential treatment opportunity is that there have been limited reported cases of patients with sickle cell disease and COVID-19. Likewise, there are blood bank shortages, and some facilities are not able to do the red blood cell exchange transfusions. In conclusion, red blood cell exchange transfusions may be beneficial to patients early on in a clinical presentation that have sickle cell and COVID-19 infection to prevent the need for intubation and ICU admission. In addition, there is potential to decrease financial costs and limit sparse resources such as ICU beds and staffing with nurses if we were able to prevent intubation and ICU admission. Thank you very much for your time. Please let me know if you have any questions or comments.